All right, we're going to get started. Sorry, we're having some technical difficulties. I don't know who organized this thing. She's a mess. Um, anyways, so our next speaker is me. I am Lula. I work in interventional endoscopy here at UC Health. I've been here for about 4 years now, and my background was in like BMT and apheresis, so I knew absolutely nothing when I came to GI. And I've fallen in love with it. And so one of the things I knew absolutely nothing about or that it even existed was Barrett's esophagus. So we're going to talk about that today. So we'll start with a brief overview, and then I'll do a very quick spiel on clinical management, like what people would do on an outpatient basis. And then we'll talk a little bit more in depth about therapeutic interventions for Barrett's esophagus. So what is Barrett's esophagus? It's a condition where the lining of the esophagus is damaged. Normal tissue is replaced with metaplastic columnar epithelium containing both gastric and intestinal features. So basically, you've got your normal esophagus, and then instead of your normal esophageal mucosa extending down to your GEJ, you start getting this salmon-colored abnormal mucosa growing up. So it's diagnosed by the finding of that in the esophagus 1 or more centimeters beyond the GEJ. So it does get misdiagnosed. A lot of times we do get referrals, and it's just kind of like an irregular Z-line, but it's just barely. And then, so the definitive diagnosis is a biopsy is positive for intestinal metaplasia. So who is at risk? We have the majority of these patients are of the male gender assigned at birth, over the age of 50 years with Caucasian heritage, and have a family history. Those are kind of like you can't modify those risk factors. And then other things that will increase your risk of developing Barrett's esophagus is tobacco smoking and alcohol use, obesity, and then chronic acid reflux, H. pylori, and a hiatal hernia. I think in that previous picture, they have a hiatal hernia. You just have more of that refluxive acid because of that. So signs and symptoms, it's not super common to always have symptoms with Barrett's esophagus. Frequent heartburn and regurgitation of stomach contents is what we'll see most frequently. About half of patients with Barrett's report little to no symptoms at all. Others will have dysphagia and chest pain. Again, those are less common. I just kind of threw this picture in here, but this is just kind of a visual of what I was talking about with that salmon-colored mucosa. Okay, so complications, why do we worry about it? It's the only known precursor lesion of esophageal adenocarcinoma. Patients with Barrett's esophagus are at a slightly higher risk than the general population for developing esophageal cancer. So it's something that it'll increase your risk, but that doesn't mean just because you have Barrett's, you're going to get esophageal cancer. However, you don't get esophageal adenocarcinoma without having Barrett's, if that makes sense. So you have a less than 1 in 200 chance of developing esophageal adenocarcinoma if you have Barrett's, and then about 90% of Barrett's cases do not develop into cancer ever. So I have a photo here of what that cancer may or may not look like. It's very ulcerated. And then here we have an endoscopic ultrasound, which is another procedure that we do in the lab. This one is done with a radial scope, and it gives us kind of this circumferential view of the esophagus. And so you can see this is this hypoechoic, which means darker area here is the mass. And then you can kind of see it penetrating and how deep it goes. And that's how our physicians stage tumors. And also, if we're evaluating whether we can do an ESD on this patient or not, if it hasn't penetrated into the muscle layer, then we'll do everything we can to do a resection rather than an esophagectomy. Those procedures, I mean, we do them, or the patients will go to surgery if they need to. However, there is a high risk of complications with those. So if we can avoid that, it's what's in the best interest of the patient. Okay, so clinical management. This is kind of the algorithm that we follow. So we have that weird abnormal mucosa. And so to get our definitive diagnosis, we'll first do biopsies. And then depending on what those biopsies come back as, that is where their treatment plan will go. So if they have non-dysplastic Barrett's, we'll see them in 3 to 5 years for repeat biopsies. We'll reassess, see how much has changed, if anything. I'm going to skip that one. We'll go over to confirmed, that's low-grade dysplasia. So then we'll go through therapeutic interventions. Same with high-grade dysplasia. And then T1, again, that's staging. So if it hasn't penetrated into that muscle layer, endoscopic eradication therapy. If it's indefinite, we'll go ahead and optimize PPI therapy. I'm going to talk about that in a bit. And if it's confirmed, EGD with biopsies in 1 year, or manage per new histology. And sorry, I'll not repeat EGD, we'll repeat biopsies. That's what that's for. So as far as clinical management, we'll manage the GERD symptoms with, the usual suspects. I would say most commonly, we are prescribing these patients proton pump inhibitors. That is we're doing that with the intent of lowering stomach acid and, keeping the Barrett's under control as much as we can. It's definitely something that as nurses, we can educate our patients on, why it's important and why it's important to take it correctly, on an empty stomach in the morning and then taking that second dose in the evening. I think that's where a lot of patients, I'm guilty of it as well. Just, they forget, or it's like, oh, you're already halfway through dinner. I'm just not going to take it. Or I'm taking it in the morning. I don't have any heartburn. I feel fine. And then things can get worse. So Barrett's with no dysplasia, monitoring of progression. Oh yeah, I already said that. 3 to 5 years. So now we'll get into therapeutic endoscopy for Barrett's esophagus. So these are the things that we're doing over in the endoscopy center. The first one I'm going to talk about is radiofrequency ablation. This is for Barrett's esophagus that is not nodular. So you're not seeing any actual raised tissue, anything like that. You had high-grade dysplasia or low-grade dysplasia. This is kind of like your first line, not as invasive. Let's try and get rid of it this way. So it uses heat generated by radiofrequency energy to destroy the diseased tissue. So basically, we're just zapping it. I'll show you kind of what that looks like here in just a moment. Radiofrequency energy is delivered either circumferentially, so we can do the whole esophagus if we need to, it's a balloon-based device, or focally with just kind of little strips that we can go systematically throughout the area that's affected. This treatment's highly effective, which is great. It has about 81% complete eradication at 12 months in high-grade dysplasia and 91% complete eradication in 12 months in low-grade dysplasia. Again, this is for non-nodular Barrett's, so you can't just zap something that's already grown into something. But if it hasn't, good news for patients. Okay, so this is what we use at this facility specifically for RFA. We use a standard upper scope, and then we have this little energy generator. It's not that little. And then our RFA catheter. We have different sizes, different shapes. Like I said, there's the balloon. This is the part that goes in contact with the mucosa. We have different lengths, different sizes, and that is decided by the provider. The way they decide that is the extension of the Barrett's, how many times it's been treated before, etc. Okay, and so here's kind of a graphic of what RFA looks like. So first is this balloon for the circumferential. So it goes down as a small catheter, and then we inflate the balloon, and then we can ablate 360. We don't use that as commonly. More commonly, we have in this facility, we'll use the focal ablation device, which is the one I was talking about. It looks like a little baseball cap when it goes on the scope. And then we'll apply direct contact to the mucosa. And usually, again, depending on the size and the energy that is being delivered. On this guy here, that'll tell you how many times you've ablated, the energy that you're using. It's this particular company, it defaults to settings per catheter, which is nice, so you don't have to think about it. All righty. So we got a little video here. And I'm gonna fast forward through some of these videos a little bit just because I wanna like show you the point of it all, but we don't need to sit here and watch the whole thing. So maybe. We'll come back. All righty. So some nursing considerations for, okay. Nursing considerations for RFA. In procedure, something that's important so that we can have good contact with the skin is to avoid excessive moisture. So for these procedures, we do not use like the normal water-based lubricant that we use in pretty much every procedure. You'll see, I think in that video, if we can get it to work, Dr. Wani dipped the scope in water first. So there is some lubrication, but usually either the tech or the anesthesia provider will kind of help with the jaw thrust to get it down because it is like this baseball cap looking thing on the end of the scope. And then always be mindful of the processor and alert the scoping physician. So again, the processor that we use in this facility, it'll say how much energy is delivered. And, that can vary based on a few things. If there's a bunch of tissue sloughing off, if the catheter is getting dirty, if, this is a teaching hospital. So if it's a newer endoscopist that's working on things and, they're very focused on what they're doing, especially because you have to stay in the same position to zap more than once. So it's always helpful as a tech to kind of pay attention on that processor. It'll tell you, how much energy is being delivered. And so if you're consistently seeing like 50, 60, that means, it's not as effective. That, those numbers, that 81%, that 91%, that is with an effective delivery of RFA. So we want to make sure that that's, and, communicate it in a productive way. And then, so yeah, you'll document, in our facility, we've in the past documented our energy used and the number of ablations. Usually physicians want that number. And then mild throat pain can be anticipated. We usually advance diet as tolerated. I'm sorry, I forgot to write that in there. And again, this emphasis on the BID PPI therapy. And then if the patient's on anticoagulants, we'll have them resume per the physician recommendation. Okay. All right. We're just going to keep going. All right. So next we're going to talk about cryotherapy, which is really cool. That was a cold joke. Okay. This is where you laugh. Very funny. Okay. So cryotherapy is another option that we have to treat Barrett's. It's usually not the first line of defense. There are other interventions that have been in place. A lot of times, I just did one with Dr. Bilal yesterday. It'll be, the patient had a ESD prior, they're coming back, and we're just, trying to get that area as much as we can so nothing grows back. So it kind of works in two waves. So the first wave is it forms ice crystals by freezing water in intracellular, extracellular tissues, and that kills them immediately. So it's, it's like frostbite, tissue dies. And then the degree of cell death is compared from that just alone is comparable to RFA. And then that second wave is that cells that survive the direct injury die as a result of mitochondrial injury. There's a whole system of things that happened, but I figured that was a talk for another time. Okay, so there's two main forms of cryotherapy. This is kind of the older, more frequently used in the past. We still do it. Again, I just did it yesterday with Dr. Bilal. So we use liquid nitrogen. And so this is a contact-free, which is important to know. I'll tell you a little bit more about that in a moment as well. Hopefully I can get my other video to play. But so it's a low pressure spray of liquid nitrogen, which is delivered through a catheter of a therapeutic scope. Reaches a temperature of negative 196 degrees centigrade. And then the rapid drop in temperature is managed by venting the expanded nitrogen gas. So what happens, you've got your tank of liquid nitrogen, you're pumping it in, it's going through this catheter, you're spraying things, that's great, but then it is no longer liquid nitrogen, it turns into nitrogen gas. So the biggest thing with this procedure is we're making sure to vent the patient. So how do we do that? Again, this is what we use in our facility. This is our console. And you can see here, it's kind of zoomed in, that is where it's got its own built-in suction that comes in a kit. It comes like in a catheter. It's got a catheter and suction hookups that all fit in, as well as their own suction tanks. And so the way that we place that catheter is usually by taking a savory wire down the scope and then taking the scope off. You kind of saw Summer do something similar when we were placing the esophageal stent in that live case earlier. So as a tech, you'll hold and the scope will come off, and then we will feed the venting tube over that down to ensure that we're past the GE junction, because we don't want to be applying all that suction just like into the esophagus. And then we'll go back down with the scope. And this is a very dramatic picture of the catheter, but that's what's on the STERIS website. Okay, let's see if we can get this one to play. Maybe. Oh, that's a bummer. Well, this one is not a link. This one was like a video that was saved and then put on like a picture. Okay, we'll come back. Okay, so then we have our other type of cryotherapy, which is the cryoballoon. This is a newer therapy. It's pretty cool. Both the liquid nitrogen and the balloon have pros and cons. I think they both very much still have a place in the treatment of Barrett's esophagus. So the way this works is it ablates mucosa via direct contact, kind of. It's an inflated balloon that's filled with the nitrous oxide. So the balloon catheter is inserted through the working channel of a therapeutic scope. And then a canister with nitrous oxide is attached to an insufflation device, which is controlled by the scoping physician via foot pedal, which is a lot. Okay, so basically this is the canister. It looks quite big, but it goes on top of this guy right here. It'll screw in the top. And then you have your catheter there. It's a balloon. But I really wanted to show you kind of how it looks down here. So this is what you've got that you're going to be treating. And then you push the catheter out. This is with an inflated balloon. And you can kind of see in this photo, hopefully a little bit. It kind of reminds me of like a train whistle. There's like this little mouth on there. And with that foot pedal, the provider not only applies the sprays, but then also can move that little mouth up and down and around. And then this is post-treatment after healing. So immediately it doesn't look like that. The tissue can be ulcerated or frozen. That's more what we would look like. And so, yeah, this is more of like an intra procedure. situation. Okay, so nursing considerations for the liquid nitrogen. This is a big one. Ensure that the liquid nitrogen tank is full prior to procedure. We are very lucky. We work in a huge facility here. We pretty much like have everything available at our fingertips, which is super nice. But that's not the case for a lot of hospitals. And even here, sometimes, we can't always get liquid nitrogen because our main tank is not full. Our nurse navigators do a really good job of seeing these procedures, identifying, okay, this is a potential, and it's communicated through our nurse manager, our associate manager, and usually the day before, ideally, we will make sure that that tank is full. And then the other thing to know for the safety and efficacy of this intervention, the machine takes a decent amount of time to set up, and it is a lot of what it's doing is releasing pressure, and it's very loud. So I usually recommend setting it up. You won't not opening anything, but at least turning it on and letting it calibrate because it's very, very loud, and it can be kind of jarring to patients when you bring them in the room. And it's just kind of like these super loud spurts of, yeah. And then the other thing, I kind of touched on this earlier, is ensure the ventilation of gas is occurring throughout therapy. As a nurse, you're really going to want to assess before you get started with anything, make sure like the abdomen is soft. And during the procedure, again, be checking that the entire time. And then document, again, this is going to vary based on your facility, but how much you've used. And also with the liquid nitrogen, I won't get super, super into it, but you will also document how many sites that you have applied the liquid nitrogen to. And this is an endoscopist thing, but the liquid nitrogen, we don't come into direct contact with the mucosa. Again, it gets super, super cold. And it's like that movie, A Christmas Story, where the kid gets stuck to the telephone pole because he's licking it. So we don't want to do that. Sometimes it does happen, but we don't want to cause more tissue damage than we're trying to do, like damage things that we're not trying to damage. And then for the cryo balloon, the assisting nurse will be holding that insufflation device. The device has a timer that counts down for each spray to ensure maximum effective therapy. You guys all got to meet Dr. Wani. He moves at 100 miles an hour at all times. And so it's nice to have a visual of like, you have 10 seconds, that way we all hold ourselves accountable and give the patient the best care. And then especially for the cryo balloon, the spray catheter can be kinked and lose effectiveness. Same with the liquid nitrogen. So pay close attention to the physician and keep the catheter as straight as possible. Because again, even though that pedal can kind of move, that doesn't mean that, sometimes the doctor won't have to like change his position. And so just move with your physician, pay attention to what's happening in the room. Okay, and then our last two interventions, I'm going to go over these a little bit more briefly. So we have our endomucosal resection, which Marcy had a full talk on this morning. We do it a little differently for Barrett's esophagus, and we'll go into those differences. And then there's also endoscopic submucosal dissection. It's very similar to POEMS, not the same, but in the same genre. So this is for lesions that extend into the submucosa, but not the muscle layer. So again, if we think back to that picture of the ultrasound, if the physician sees that it's penetrating into the muscle layer, unfortunately, like that needs to be surgically resected. And so EMR, the tissue is removed via cautery and a snare, like we saw earlier. So there's the lift and cut method, which is what Dr. Muthing was doing. And that's what Marcy went over. And that's an agent injected into that submucosa and then resected with a snare. And then there's the ligate and cut, which is the main thing that we do here. And the tissue is banded with an over-the-scope litigation device and then resected with a snare. So I'm sure a lot of you most of you have experience with banding esophageal varices. It's like that, but we're not banding and cutting off varices. But it's very similar device. You get the rubber band around the tissue after sucking it up into the scope, and then you snare it off. And then our ESD, the target lesion is removed using a specialized endoscopic knife by dissecting through the submucosa. So similar to poem in the fact that you're going underneath and you're cutting with the knife injects as well, but instead of going past the submucosa into the muscle layer, you're not doing that. You're just cutting under the lesion and lifting it off. All right, so I have some photos here. And so this is some nodular tissue. You can see how it's like bumpy here. So that's not something that we could RFA. And then it's very common for providers to first use some soft coagulation to mark where they're going to be resecting. Because once you get started, especially with this cap, you can kind of see it definitely affects like your field of view. You want to make sure you're getting the extent of everything and you know where you're at. It's like a bookmark. And so this is the cap on. And in this, the provider is sucking up the mucosa. Ideally, you want to have a red out similar to varices, and then you deploy the band, which is figure D. And then figure E, it's kind of hard to see in that photo, but that little white, this right here is a snare. And so then you'll close and use cautery. This is a situation where you definitely want to be in communication with your provider and how your snare feels when you close. If it's super bouncy or it feels like you have too much, that's always something to communicate. This device is very effective in separating the mucosa from the muscle layer, but we always want to proceed with caution. And then this is what it looks like after we have resected that bite. And then as far as ESD goes, this is illustrated, but it's a pretty good indicator. So this is the area that we're going to be taking off. ESD is nice because you take the entire lesion and then you can ensure that you have negative margins, very low likelihood of that lesion returning. And this is what it looks like after an ESD so that you can see that entire area was taken off. I wish it happened that quickly. Usually those procedures are very long, a couple hours. All right, so I have a picture here of what the outside of all of that looks like. So you'll have your band litigation kit. Again, it is just like kind of like this little crank device. There's different brands. It looks similar to the over-the-scope Ovesco that Dr. Wani used earlier. And then you have a snare. It's a hexagonal snare that comes with the kit, and that's what you use to resect. And then for your ESD, it's kind of hard to say like exactly what you'll need. Very similar to POEM in that you'll have this specialized knife. Usually the knife has the option of injecting fluid. And then so you'll still need cautery and a lifting agent, very physician preferred. And additionally, if you're ESDing, something in the esophagus, you may need a different tool than if you're doing something that's like going through the GEJ to the cardia. The last thing I wanted to say about those two is post-procedure, especially depending on the extent of the resection or dissection, patients do run, there is a risk of that kind of scarring down and patients developing a stricture. And so that is unfortunately an expected finding, but they just come back and we do some dilations, usually inject some Kenalog, and they do pretty well. Sometimes they have to come back a couple times. Yes. Between the band and the area cut up, or between the band and the which band and mucosa. Yeah. Every once in a while, like, correct. Yeah, that's not a stupid question at all. That's a very good question. Yeah. Yeah. All righty. Okay. See if none of the other video I have is working, guys, I promise. So I have an ESD video I'm going to show you here. Where did it go? Oh gosh. Okay. All right. So I'm going to go ahead and play this. So you can see this lesion right here. Oh, where's my thing? And the physician has marked this lesion. That's what you see those cautery marks are. This is kind of hard to tell, but right now this is the submucosal dissection. You saw they just injected into the submucosa. We always use blue, and it just, again, helps us stay away from that muscle layer. Things get really topsy-turvy and hard to see when you're doing ESDs in the esophagus. So what you're looking at here is we're cutting through, so that's the other side of the lesion. So he has tunneled under and is cutting through the other side. And I don't know if you appreciated this, but you can see that different types of knives have been used during this. And again, it's just like how long they are, how like the shape of them, those are the things that we're looking at. So we're close to separating the lesion from the esophagus at this point. And sucked it up. So at this point, what they're doing is using a coag grasper to cauterize some vessels that were exposed just to reduce the risk of bleeding. And you can see all of the resected tissue underneath there. Back to my PowerPoint. All right, so nursing considerations. Where is my... you want to note your cautery settings. We use RMIE for our
Michael,
cautery
the
here.
first video.
Thanks, Jacques. So, Jacques, this is an 85-year-old medical professional.
Oh, this is just autoplay. Okay, thank you. Oh, okay. Note your cautery settings. Again, we work in a big facility. We're very spoiled here. We have all of our pre-settings on our devices, but I still always double check with the physician. Hey, is this what you want? Especially on RRBs, there's different settings for incisions, for tunneling, if we're using the tip of the snare to coagulate something, if we're using the coag grasper. And it varies from procedure to procedure. And then communicate throughout the procedure. I feel like we talked about this a lot with Dr. Muthing and with Marcy this morning about like a closed loop of I am closing this snare after, the MD says I'm closed snare, I am closing this snare. How does it feel? It feels like this. Especially, again, sometimes with that cap, you have poor visualization. And so, we're used to doing a quick colon and taking off like a 2 millimeter polyp, like they can see that the snare is closed and you're ready to go. But not always in these situations. And so it's very, very good to have that closed loop of communication. Again, be mindful of space, equipment, and cautery. It's always good to have, if you're able to in your facility, it's always good to have a backup scope. If you're doing an EMR like this, just out in the hallway or somewhere that you can run and grab it if you need to do something quickly, because it's not as easy to throw tools down. And it's sometimes nice to have another scope that you can plug in and go if you need a cap or things like that. And then that way, because if you take that litigation device off, you can't put it back on. So, and then for ESD, similar to with the cryo, you always want to perform a baseline intra-procedure and post-procedure assessment. We are going into third space, the submucosa, not never, never land, but with that, there's always a risk of perforation. So we just want to make sure baseline that the abdomen is soft, or how soft it is. Some people, baseline aren't very soft. And so that way, where you're coming from if you have concerns about that. And additionally, in the neck, it's also good to feel the neck, any signs of crepitus, that sort of thing. Again, that would be a sign that CO2 is going where it's not supposed to be going. And then I always just, for these procedures, our patients are intubated. Our anesthesia carts that we have in our rooms will let you know the peak pressures. So that is something I always just kind of glance at to see that it's staying stable-ish throughout the procedure. And then they also talked about this in the poem earlier. Note the level of insufflation. Does the provider want to be on ultra low or low? Especially in the esophagus, you guys saw how confusing that video is. Like, what is up? What is down? Where am I? So sometimes they'll have you turn up the insufflation for a second just so they can kind of get their bearings again. But it's always good to, ask, hey, do you still want to be on medium CO2? And then typically we pin these specimens just to take pictures, and then also get a bearing and look at the edges of the lesion, because ideally you want to take off more than the lesion so you have negative margins and that it does not return. All right, there are my sources. I apologize about the videos. I don't know if we're going to be able to get them to play, but do we have any questions? Yeah. Oh, the mics are off. Yeah, sorry. No, you can turn it on. Just the thingy.
Patient that has a pretty decent prenatal hernia on PPI, do you think they would automatically go on PPI to Barrett's from happening?
That's a great question.
Dr. Wani, where are you?
Yeah, that's it. Oh, we also have one of our fabulous physician's assistants here. Do you have any idea? Okay. That makes sense. Yeah. If they're symptomatic. All righty. Well, speaking of our fabulous PAs, we have Colette Crane coming up. Oh, sorry. Oh, I'm sorry. I didn't see ya. Of course. You can ask 3. Yes. That's a good question. I believe that Dr. Wani prefers the balloon at this point. It just logistically is a lot easier to achieve. That is one, but also what was I trying to say? Where's my train of thought? It's just as effective, right? And so I think it's provider preference a lot more than anything, because they have pretty much the same efficacy. And I can send you some articles if you want. There's been a few reviews. So yeah. Yeah, thanks. Okay. All right.